Welcome to the Hospital Medicine Unplugged podcast.
Today we're diving deep into pneumothorax. It's something we see everywhere, right? From the general wards up to the ICU, air getting into that pleural space, causing lung collapse.
Yeah, it's a really frequent cause of acute respiratory compromise. And it pops up in so many ways spontaneously, after trauma, or often for us hospitalists, iatrogenically, after putting in a central line or doing a biopsy.
Exactly. So our goal today is really to pull together the latest evidence. We're looking at consensus statements like from the ACCP and some really important recent data like those studies in the NEJM.
Right. The aim is to figure out how we optimize outcomes, obviously, minimize complications, and this is key, understand when we can actually avoid unnecessary interventions in our patients.
And that's the big shift, isn't it? There's this evolving paradigm. For years, it felt like almost any pneumothorax automatically meant a chest tube.
Definitely the default.
But now, we've got solid evidence showing that for certain stable patients, conservative management, just watching them, is often just as good, maybe even better.
Which is a huge contrast to the critically ill patient, where you need immediate, decisive action.
Yeah.
Tension physiology, that's a whole different ballgame.
Absolutely. That's the clinical balance we need to strike. So maybe let's start by just laying out the classifications. Even though we're focusing more on size and symptoms now, the why still matters for prognosis and how we think about management.
Makes sense. Ground ourselves first.
Okay, so broadly, 4 main types. You've got spontaneous pneumothorax, and that breaks down further into primary PSP and secondary SSP.
Right. PSP is the classic young, tall, thin person, maybe a smoker, no obvious lung disease.
Traditionally, yes. And then SSP secondary is when there's clear underlying lung disease. Think COPD, cystic fibrosis, ILD.
Or those rarer things too, like lymphangioliomyomatosis. Important not to miss.
Crucial differential, yeah. But here's a nuance we need to appreciate now. This strict PSP-SSP split. High-resolution CT scans are kind of blurring those lines.
How so?
Well, studies are showing a pretty significant number of patients we label as primary actually do have subtle issues, tiny blebs, subpleural bullae that a standard chest x-ray just wouldn't pick up.
Ah, okay. So just because it looks like PSP initially doesn't mean the lung is perfectly healthy underneath.
Precisely. It reinforces why we really need to manage based on the size of the pneumothorax and how the patient is doing physiologically, not just stick rigidly to that initial PSP label.
Good point. Okay, so that's spontaneous. Then we have the types we often cause ourselves in the hospital, iatrogenic.
Right. Procedure-related. Central lines are the classic example, especially the subclavian approach. But also lung biopsies, certain ablations, even positive pressure ventilation, both non-invasive and mechanical, can cause barotrauma leading to this.
And then traumatic blunt or penetrating chest injuries. Often comes with other things like rib fractures, hemothorax.
Yep. And finally, the one that demands immediate recognition. Tension pneumothorax. As you said, it's not really an etiology itself, but a life-threatening syndrome.
A complication of any of the others.
Exactly. And the pathophysiology is terrifyingly simple. Air gets trapped in the pleural space, can't get out. It builds up pressure.
Like a one-way valve.
Exactly. That pressure pushes the mediastinum over, compresses the other lung, and crucially, it kinks the vena cava.
Cuts off venous return to the heart.
Leading to circulatory collapse. Fast. It's a true emergency.
Okay, so how do these different types actually look when the patient presents? Usually starts with that sudden chest pain, right? Pleuritic, sharp, and shortness of breath.
Typically, yes. But the degree of dyspnea is often the most telling sign, especially differentiating PSP and SSP clinically.
How so?
Well, think about it. A young, healthy person with PSP might have a decent-sized pneumothorax but feel only mildly short of breath because they have so much pulmonary reserve.
Right.
But take someone with severe COPD, an SSP patient. Even a tiny pneumothorax can push them over the edge. Their dyspnea can be immediate, severe, completely out of proportion to the size on imaging.
Because they have no reserve left.
Exactly. That's why SSP is inherently higher risk and why our threshold for intervening is much, much lower, even for small ones.
Makes sense. What about the physical exam? We all learned the classic signs, tachycardia, decreased movement, hyperresonance, diminished breath sounds. How reliable are those?
They can be there. You look for them. Tachycardia, maybe one side of the chest isn't moving as well. You percuss and it sounds drum-like. You listen and the breath sounds are faint or gone. But honestly, in practice, especially with smaller pneumothoraces or in patients with significant existing lung disease or obesity, these signs can be really subtle or completely absent. absolutely cannot rely on the physical exam alone to rule it out.
Okay, so the critical pivot point for us is identifying tension physiology. What are the absolute red flags that mean act now, don't wait?
It boils down to hemodynamics. You're looking for instability, hypotension, persistent tachycardia, maybe severe hypoxemia, signs of shock.
And those textbook signs like tracheal deviation, distended neck veins.
We learn them, but we have to internalize this. They are late signs, very low sensitivity. If you see tracheal deviation, that patient is already crashing or about to. You cannot wait for the trachea to move.
Right. If we're waiting for that, we've probably missed the golden window for intervention before arrest. So what specific vital sign thresholds should really set off alarm bells?
Any sign of shock, obviously, combined with acute respiratory distress, but specifically persistent tachycardia, say, consistently over 135 beats per minute or new onset hypotension or central cyanosis. If you see those, tension has to be right at the top of your differential.
Especially in a ventilated patient.
Oh, absolutely. Positive pressure ventilation just pours fuel on the fire. The ventilator forces air into that pleural space, and they can go from stable to hypotensive or even into asystole incredibly quickly. Minutes.
Which perfectly underscores the rule. Tension is clinical. You treat before you image.
Non-negotiable. If the clinical picture screams tension, you decompress immediately. Needle first, or straight to a tube if you're set up. Don't waste precious time calling for a stat portable chest x-ray or trying to get them to CT. Treat the patient.
Okay, so assuming the patient isn't in extremis, or after we've stabilized them, imaging comes next. Chest x-ray is usually the first step. What are its main drawbacks, especially in our hospitalized, often supine patients?
It's accessible, which is good, but yeah, limitations are significant, especially supine films. Air doesn't layer out nicely at the apex like on an upright film. It goes anteriorly, inferiorly.
I'm giving you that deep sulcus sign.
Right, which can be subtle, or you might just see increased lucency over the lower chest or abdomen. Point is, it's easy to miss a pneumothorax entirely on a supine film. And missing one, an occult pneumothorax, can be lethal if you then decide to put that patient on positive pressure ventilation later.
Then there's CT chest.
CT is the definitive test, gold standard. It finds everything, tiny pneumothoraces, occult ones. It lets you estimate the size much better, and it can show you the underlying lung, maybe those blebs we talked about in PSP patients.
But it's not always practical for unstable patients.
Exactly. Logistics can be tough. Transporting a potentially unstable patient, it takes time. So CT is usually reserved for cases where the diagnosis is unclear after X-ray, or maybe in stable trauma patients who need a full body scan anyway.
Which brings us to the real star of bedside diagnosis now, thoracic ultrasound, POCUS.
Yes, POCUS has been a game changer here. The Society of Critical Care Medicine actually recommends using it alongside or even instead of chest X-ray for rapid diagnosis at the bedside, especially in the ED or ICU.
And the accuracy is impressive.
It really is. When done by someone trained, the sensitivity is usually quoted above 85%, and the specificity is phenomenal, over 99%.
Wow. What's the key finding you're looking for?
It's the absence of lung sliding. Normally, the visceral pleura slides against the parietal pleura with breathing. You see this shimmering artifact on ultrasound.
Right.
If there's air between those layers of pneumothorax, they can't touch, so that sliding disappears. Finding the exact spot where sliding stops and starts again, the lung point, is basically 100% specific for a pneumothorax. It's fast, non-invasive, right there at the bedside. Invaluable.
Okay, so we've diagnosed it. Now, managing it often depends on size, but you mentioned guidelines differ on how to define large versus small. Are there tools emerging to help quantify things better, especially air leaks?
Yeah, that size definition issue is tricky. Different societies use different cutoffs, like 2 centimeters versus 3 centimeters from the chest wall. It does complicate things. But for monitoring after intervention, digital air leak monitoring systems are a huge step forward.
How do those work compared to the old water seal chambers?
Instead of just watching for bubbles, which is pretty subjective, these devices give you actual numbers. They quantify the air leak flow rate, usually in milliliters per minute, objective data.
And how does that help clinically?
It takes the guesswork out of deciding when the leak has stopped. You can set a clear threshold, for example. Remove the tube if the leak is less than 20 mmmin for 6 straight hours. No more clamping trials, which carry a risk of causing tension.
Right.
Studies show these digital systems lead to less variation in practice, earlier chest tube removal, and shorter hospital stays. It's just more precise, objective management.
It definitely sounds like an improvement. Okay, Let's dive into the core management strategies now, based on the type and stability, starting with the absolute emergency, tension pneumothorax.
Right. Immediate action, needle decompression first, usually. The classic teaching was second intercostal space, mid-clavicular line.
But that's being revised.
It is, because chest wall thickness varies a lot, especially in adults. A standard angiocatheter might not actually reach the pleural space in the second ICS. So many guidelines now suggest the fifth intercostal space, anterior axillary line, as an alternative or even preferred site.
What's the advantage of the fixed space?
It tends to be a thinner spot on the chest wall, increasing the chance a needle gets in. And anatomically, it's generally considered safer, less risk of hitting the lung itself or major vessels like the subclavian or internal mammary artery, less risk of causing a massive hemothorax.
Okay, so needle decompression buys you time, converts the tension, then you need definitive drainage. What size chest tube does ACCP recommend here?
For tension or suspected large leaks, they recommend a 16 French to 22 French tube. Gives you reliable drainage. You might go even larger if you suspect a bronchopleural fistula or if the patient needs high levels of positive pressure ventilation just to minimize the risk of the tube clogging.
Got it. Now let's swing completely to the other side. The stable primary spontaneous pneumothorax, PSP, where the big paradigm shift is happening.
This is where things have really changed thanks to those recent RCTs, like the big one and the NEJM. They directly compared conservative management versus putting in a chest tube right away for stable PSP.
And what did that NEJM trial show?
The main finding was non-inferiority. Conservative management, basically, observation, maybe some supplemental oxygen, was just as effective as intervention in terms of radiographic lung re-expansion at the 8-week mark.
So the lung eventually re-expanded just as well without the tube.
Exactly. And importantly, the secondary outcomes strongly favored the conservative group.
Like what?
Shorter hospital stays, significantly fewer adverse events, less pain, fewer infections like empyema, fewer issues related to the chest tube itself. For a young, otherwise healthy patient, avoiding that tube is a big win in terms of morbidity and getting back to normal life quicker.
Sounds great, but who exactly qualifies for this hands-off approach? The selection criteria must be strict.
Absolutely critical. The patient must be clinically stable. That means no respiratory distress, good oxygen saturation, say 92% on room air or just a little nasal cannula, normal blood pressure, heart rate generally under 120.
And minimal symptoms.
Minimal symptoms, yes. And importantly, they need to be reliable, able to understand the plan, tolerate observation, and crucially, be able to come back easily for follow-up checks and imaging. If they seem unstable, are very symptomatic, or you worry about follow-up, conservative management is off the table.
Okay, so if the PSP patient is symptomatic or the pneumothorax is deemed large, intervention is needed. What about needle aspiration as a first step before a chest tube?
Needle aspiration is a really good option. It works, meaning it gets the lung up and avoids a chest tube in up to about 70% of stable PSP patients.
And how does it compare to tubes long-term?
Meta-analyses suggest the initial success rate is a bit lower than going straight to a tube, but the long-term recurrence rates seem pretty similar. And if it does work, it can dramatically shorten the hospital stay or even allow for outpatient management. It's a great, less invasive first try.
If aspiration doesn't work, or for larger symptomatic ones, then it's chest tube time. And here, too, there's been a shift in thinking about tube size, right? ACCP consensus.
Huge shift. The strong recommendation now is for small bore chest tubes, typically 14 French or smaller, as the first choice over the big ones we used to use.
Oh, why change?
The evidence is pretty clear. For just draining air, these small tubes work just as well as the larger ones, but they cause significantly less pain for the patient and probably fewer complications during insertion.
That makes intuitive sense. But practically speaking, you still see larger tubes being placed, especially in trauma or ED settings. Is it just habit, or is there still a role for large bore?
That's a fair point. There's definitely some inertia, some habit involved. And to be clear, large bore tubes like 28F, 32F absolutely still have a role, especially if you're dealing with hemothorax. You need that bigger diameter to drain blood and clots effectively.
Okay.
Or if you anticipate a really massive air leak, maybe from a known bronchopleural fistula. But for the standard uncomplicated pneumothorax, most PSPs, most iatrogenic ones, the evidence supports starting small, like 10F or 12F. The barrier is often just getting comfortable with the technique, but the patient benefit in terms of pain is substantial.
Once the tube is in, initial management is usually just to a water seal device or maybe a Heimlich valve. When do you add suction?
Right, start with water seal. You only really need to add suction, usually gentle suction, like negative 20 centimeters of water if the lung isn't re-expanding properly on water seal alone, or sometimes if the patient is on positive pressure ventilation.
Does suction help seal the leak faster?
It can sometimes speed things up, but it's a double-edged sword. Sometimes applying suction can actually prolong the air leak once you try to take the suction off. And there's also a small risk of causing re-expansion pulmonary edema if you reinflate a collapsed lung too quickly with high suction. So generally, water seal first, add suction only if needed.
Okay, good clarification. Let's move into those higher risk groups now. What about secondary spontaneous pneumothorax, SSP?
Yeah, SSP is different. Remember, these patients have underlying lung disease, often severe COPD or fibrosis. Their reserve is minimal, so the threshold for intervention is much lower.
Meaning chest tube drainage is generally the way to go.
Generally, yes. Even for pneumothoraces that look relatively small on the X-ray. Conservative management hasn't been studied nearly as well in SSP, and the risks of respiratory decompensation are just too high. Prompt drainage is usually preferred.
How does that compare to managing iatrogenic pneumothorax?
Iatrogenic is more of a spectrum. It really depends on the patient and the situation. A tiny asymptomatic pneumothorax after, say, a careful lung biopsy in a healthy patient, you might just observe that closely. But if the patient has significant underlying lung disease like bad emphysema, or if they need to go on positive pressure ventilation soon after the procedure, that changes everything. The risk of that small pneumothorax rapidly worsening or turning into tension on the ventilator is high. So in those cases, you'd put in a chest tube prophylactically, even if it's small and they're asymptomatic at that moment.
Which leads us right into the most critical scenario. Pneumothorax caused by barotrauma in a ventilated patient.
Absolute emergency, no question. Positive pressure ventilation feeding air into the pleural space. It's a recipe for rapid tension development. There's no role for observation here. It needs immediate tube thoracostomy, period.
And besides getting the tube in fast, what else needs to happen immediately for these patients?
Continuous ICU monitoring, obviously. And critically, you need to adjust the ventilator settings right away to minimize further lung injury.
How do you do that? Lung protective strategies.
Exactly. Lower the tidal volumes, reduce the plateau pressures, basically use the gentlest ventilation possible that still achieves adequate oxygenation and ventilation. You're trying to let that hole in the lung heal, so you want to minimize the pressure stressing it.
Makes sense. Okay, so we've intervened, the tube is in, but sometimes the lung doesn't come up or the air leak just keeps going.
Yeah.
When do we need to get thoracic surgery involved? What are the escalation criteria?
The main trigger is a persistent air leak or failure of the lung to fully re-expand despite the chest tube being in place and functioning.
How long is persistent?
Generally, the cutoff is around 3 to 5 days. If you still have a significant air leak after 3, 4, 5 days, the chances of it resolving on its own are getting pretty low. And keeping a chest tube in for longer than that significantly increases the risk of complications, especially infection empyema.
So call surgery early if the leak persists beyond that time frame.
Yes, definitely consult thoracic surgery by day 3 to 5 if there's no sign of the leak slowing down. They have options like VATS with bleb resection and chlorodesis to definitively fix the leak.
Let's talk about prognosis now. Who generally does well, and who are we most worried about?
Well, the best outlook is clearly for the young, healthy PSP patient, especially if they were managed conservatively. They tend to recover fully with fewer complications.
And the worst prognosis?
That falls on the older patients, those with lots of comorbidities or the critically ill. So SSP patients, those with barotrauma-related pneumothorax, or anyone who develops tension physiology. Their mortality is significantly higher.
Do we have actual numbers on that?
Yeah, the data is quite concerning. For older adults admitted with pneumothorax, especially with comorbidities, in-hospital mortality can be up to 15%.
15%.
And it gets worse in the ICU. Mechanically ventilated patients who develop pneumothorax, particularly if they also have septic shock, face very high mortality rates. We also saw recently with COVID-19 that patients who developed pneumothorax, especially if they needed ventilation or had tension, had markedly worse outcomes compared to non-COVID patients with pneumothorax.
Oh, so COVID added another layer of risk.
It seemed to, yeah. Possibly due to the underlying inflammation or maybe coagulation issues affecting the lung tissue.
Okay, so mortality is a big concern in those high-risk groups.
Yeah.
What about recurrence? That's a major long-term issue too, right?
Huge issue. Recurrence rates are quite high. For PSP, even after a first episode, the risk of having another one within 5 years is up to 30%.
And for SSP?
Much higher. Because the underlying lung disease is still there, recurrence rates for SSP often exceed 50%. Factors like continued smoking, seeing bullae on the CT scan, having had previous episodes all increase the risk.
So preventing recurrence is critical. What's the first most important step?
Non-negotiable. Smoking cessation. If the patient smokes, they absolutely have to stop. Continued smoking is one of the strongest predictors of recurrence. Quitting significantly lowers the risk.
Makes sense. And for patients at high risk, like SSP after a first event or PSP with recurrences, what are the interventional options? Pleurodesis.
Exactly. Pleurodesis is the main strategy. The goal is to get the visceral and parietal pleura to stick together, obliterating the pleural space so air can't accumulate.
How is that done?
Two main ways. Surgical pleurodesis, usually done via VATS, video-assisted thoracic surgery. The surgeon might resect any visible blebs or bullae and then physically abrade the pleura or sometimes remove part of the parietal pleura, pleurectomy. This is the most effective method, reducing recurrence risk down to less than 5%.
Very effective. What's the alternative?
Chemical pleurodesis. This is usually for patients who aren't good candidates for surgery. Maybe they're too frail, have severe COPD, etc. You instill an irritant substance, often talc slurry, through the chest tube. It causes inflammation that scars the pleural layers together.
And how well does chemical pleurodesis work?
It's less effective than surgery. It reduces recurrence risk to around 25%, better than nothing, but still a significant chance of it happening again compared to the surgical approach.
What do the ACCP guidelines say specifically about prevention strategy for SSP patients, given their high risk?
Because SSP carries such high morbidity and recurrence risk, the guidelines recommend offering recurrence prevention after the very first episode. Don't wait for a second one.
That's called SARP, Same Admission Recurrence Prophylaxis.
Exactly. The idea is to address the recurrence risk definitively during that initial hospitalization. Evidence suggests this FARP approach is associated with better long-term survival for SSP patients. And the guidelines generally favor a surgical approach, VATS, if the patient is a candidate, simply because it works much better than chemical pleurodesis. Chemical is reserved for those who absolutely cannot have surgery.
Okay. Lastly, besides the air leak itself, what are some other common complications we need to watch out for while these patients are in the hospital?
Well, infection is a big one. Empyema or pleural infection developing after chest tube placement. Hemorrhage from the insertion site can happen. The tube can get blocked or dislodged. And then there's re-expansion pulmonary edema.
Right, you mentioned that earlier with suction. Tell us more about RPE.
It's rare, but can be serious. It typically happens after you rapidly reinflate a lung that's been collapsed for a while, or if the pneumothorax was very large.
What causes it?
The sudden pressure change seems to injure the capillaries in the re-expanding lung, making them leaky. Fluid floods into the alveoli. The best way to prevent it is gradual re-expansion. Avoid high suction immediately, especially on large or chronic collapses. Use water seal initially.
Got it. Okay, so let's try to pull all this together. Considering the ACCP advice on tube size, the NEJM data on conservative management, what's the main takeaway message for hospitalists managing pneumothorax today?
I think the core message is treat the patient, not just the x-ray or the label. Management has to be driven primarily by clinical stability and symptoms.
So stable PSP.
Stable PSP, carefully selected patients, lean towards conservative, observational management. The evidence supports it.
But unstable patients, ventilated patients, SSP patients.
Prompt intervention is needed, usually with a chest tube, and preferably a small bore tube, 14 French or less, if it's just air, not significant blood.
And POCUS.
POCUS is a crucial tool. Use it early, especially in unstable patients or the ICU, for rapid diagnosis at the bedside. It really helps streamline things.
So the evidence clearly shows conservative management works well for stable PSP, reducing complications and hospital stay. Thinking ahead, how might we leverage some of these newer technologies, like the digital air leak monitors you mentioned, or maybe even future ambulatory devices to push this further? Could we potentially manage more patients conservatively, perhaps even avoiding admission altogether for some, while keeping things absolutely safe and maybe even improving recurrence prevention down the line?
That's exactly the direction things are moving. Using objective data from digital monitors, maybe even wearable sensors. Could we safely send carefully selected, stable PSP patients home with a Heimlich valve or a small ambulatory drainage device monitoring them remotely? It's an exciting area, reducing hospital stays, improving patient satisfaction while ensuring safety. That's the goal. Something definitely for all of us to think about as we apply this evidence in our own practice.
A great point to end on. Thank you for joining us for this deep dive into evidence-based pneumothorax management.
My pleasure.
Until next time.